You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 19th, 2018. This week, a CMS proposal for MRI in patients with cardiac devices, bariatric surgery, statins, wearable cardiac defibrillator, spontaneous coronary artery dissection. First up is our CMS proposal on MRI scans. Finally, a sign of hope in the policy that restricts MRI in patients with cardiac devices here in the United States. This is a proposal from CMS. It's an expansion in covering MRI beyond MR conditional devices. The new draft would eliminate the contraindication for coverage for MRI and expand coverage to patients with CRTP and CRTD. But there were contingencies in this draft document. First, patients would have to be scanned with a 1.5 Tesla magnet. There would be a 6-week delay after implant. There would be no scans allowed in patients with fractured, abandoned, or epicardial leads. And importantly, the patient would not be able to be pacer dependent. And I hope this part of the draft gets changed because many of the observational studies included patients who were dependent and they did fine with MRI scans. Another crucial part of this proposal was that facilities who do this will have to have institutional protocols for pre- and post-scan care of the device. I lead with this story because it's big news for U.S. physicians because the Medicare contraindication was a huge impediment. And it wasn't just a financial issue. The other issue was that having a contraindication was a signal to those who clung to dogmatic fears over safety that this couldn't be done. Now, finally, if this pushes through, it's a small and very delayed win for evidence because the evidence supports that this is a safe thing to do as long as precautions are taken. Second topic today is bariatric surgery. Now, I have seen patients transformed by bariatric surgery, and you probably have too. And yes, of course, obesity is a huge problem, but there are downsides to this surgery. A large cohort study published in JAMA from Norway helps highlight both the positives and negatives of this big surgery. The study included about 1,900 patients, about 900 in a medically treated group and about 900 in the surgically treated group. The study was non-randomized. Patients chose what therapy they preferred. The good news, hypertension improved with treatment of obesity both medically and surgically, but surgical patients had substantially greater improvements, and it was the same with diabetes. Both groups had diabetes remission, but far more in the surgical group, 57 versus 15%. Overall mortality rates, when adjusted, did not differ between the two groups, and there were no surgically related deaths. Now, there were concerning aspects of the surgical treatment. There was a slightly higher rates of new depression or opioid use in the surgical group. Surgical patients had a greater risk for undergoing at least one additional GI surgical procedure. The absolute risk for operation for intestinal obstruction was nearly 9% in the surgically treated group and about 1% in the medically treated group. That's a 10-fold higher rate of operation for intestinal obstruction. Abdominal pain was also greater in the surgical group. Now, my comments on this are that the effects on hypertension and diabetes are similar to previous studies. The diabetes effect with surgery is impressive. The deltas, or the differences, were quite small for increases in depression and opioid use. A 2-fold greater rate of second operation on the abdomen is noted, and as is the 8% absolute rate of operation for intestinal obstruction. The authors offer a truly beautiful conclusion here, one that should be reinforced in all medical interventions. They say, although bariatric surgery has the potential to improve obesity-related comorbidities, clinically important rates of complications should be considered in the decision-making process. I think you could substitute any surgery in there and that statement would hold true. Third topic today is about statins and primary prevention. Another published article heated up the debate about statin use for primary prevention. This was a modeling study published in the Annals of Internal Medicine. Danish authors sought to compare the effects of guideline recommendations for primary prevention of cardiac events They took observational data to estimate statin effects and then did a modeling study to estimate the effectiveness of different guidelines. Now, before you hear the results, you should be able to predict the results. Statins reduce cardiac event rates. This is not new. Therefore, the guidelines with the most robust recommendations for statins, those that call for more people to take the drugs, will come out in modeling studies to reduce more events. And indeed, that is exactly what the authors found. The lowest bar to statin use was the Canadian Cardiovascular Society, which makes 44% of those adults aged 40 to 75 eligible for statins. The next is ACC-AHA, then the NICE guidelines, then USPSTF, and finally the European guidelines, which called for only 15% of these adults eligible for statin for primary prevention. The Euro guidelines, therefore, prevented the least amount of cardiac events in this modeling study. I think what is most interesting in this story is the author's quotations and comments, which were covered nicely in the Medscape Cardiology news story. The gist of the comments from the news story. The first is, just follow the American College of Cardiology and Canadian guidelines because they make more people eligible. The problem in Europe, say the authors, is that the guideline committees try to be inclusive, letting more organizations participate. Then they say this has diluted the scientific quality of the committee and given rise to these more conservative recommendations. And here's one of my favorites. Quote, many general practitioners in Europe are still so against the idea of giving medicine to somebody they believe is still healthy. And some of these voices are being given a say in the European guidelines. And finally, this is also interesting. The guidelines all consider the same evidence but come up with different thresholds for statin eligibility. Now, these are supposed to be experts. To me, this controversy calls not for more paternalism, as if there is a right answer on statin eligibility, but more work on tools to help patients decide whether the reduction in risks of non-fatal events is worth taking the pill. To me, this is up to patients more than it is up to us. It's our job to give guidance. Next up is a warning on the wearable cardiac defibrillator, or the Zoll LifeVest. This week, our FDA released a safety alert on the Zoll LifeVest. In general, the problem was that the vest failed to deliver therapy, and one death associated with this failure has been reported. Specifically, the FDA has concerns that the device may not deliver treatment if it's not replaced soon after displaying a message, quote, call for service, device has a problem that may require service, call Zoll for service, message code 102. In other words, the message code 102 does not explicitly indicate to the patient that the device cannot be used and that they should call Zoll immediately. The estimated number of patients impacted by this is small. FDA estimates 0.1% of the 33,000 devices distributed. And I don't want to use this one recall to rehash my critique of the wearable cardiac defibrillators' overuse and misuse and aggressive marketing. But this sort of thing, I believe, reinforces the need for an RCT of this therapy. Remember, there hasn't been an RCT of the wearable cardiac defibrillator. All data that we have, or most of the data, is from industry-sponsored registries. Now remember, the far more efficient internal ICD did not improve mortality in the waiting period after MI. Why would we expect this device to be better? An internal ICD doesn't have to be taken off to take a shower, for instance. But the other reason to do a clinical trial is that it would allow for independent assessment of adverse events, things like psychological stress, anxiety. Finally, the last topic today is on spontaneous coronary artery dissection. Now, this is an observational and propensity match study which should immediately give you caution. But in the case of spontaneous coronary artery dissection, perhaps it's best not to intervene with PCI. These were the conclusions of a group of researchers who queried the national inpatient sample for the diagnosis of acute MI and concomitant spontaneous coronary artery dissection. The study scanned nearly 750,000 eligible women, and of those, about 7,300 had spontaneous coronary artery dissection. Interestingly, in-hospital mortality for this condition has dropped from the beginning of the study in 2009 to the end of the study in 2014. But that's not the big news from this study published in JACC Intervention. I think the big news was that this decline in mortality over the study period was associated with less PCI procedures. The rates of doing PCI for spontaneous coronary dissection dropped from 82% at the beginning of the study to 69% in 2014. And the authors also found PCI was associated with higher mortality in patients with non-STEMI. Another finding that surprised me and I would not have expected was that the odds ratio for inpatient mortality for spontaneous coronary dissection compared with AMI without spontaneous coronary dissection was nearly 1.9. That's almost a twofold higher rate of death with dissection. Well, since lower rates of PCI were associated with improved survival, the authors wrote that these findings support the current recommendations for conservative management being the preferred initial strategy for management of AMI in women with spontaneous coronary dissection. And it's important to note, as the authors did, that this is an observational study. The comparison groups were not randomized, and even with propensity matching, there is a strong possibility of unmeasured confounding variables, meaning patients with dissection who had PCI might have been inherently sicker than those who did not have PCI. That said, there are plausible reasons why PCI would worsen dissection. Finally, to me, the most curious thing of this story is why women, not men, have dissection of a coronary artery just out of the blue. And to me, that needs more research. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.